Hello everyone and welcome to today's Ealthy webinar. My name is Bethan Edwards and I'm just introducing the session today. So a few things for housekeeping. If you have any questions during the session about the technical side or anything like that, please pop your questions into the chat box and we will be on hand to help with anything like that as far as we can. We will have time at the end of the session for questions and answers. So if you have any questions for Alan during the session, if you can click on the Q&A button and post your question in there, then we'll come to those at the end. Today's session is being recorded and it will be available via the Ealthy website on in the members section. So if you're not yet a member of Ealthy, there's lots of great benefits, including lesson plans, recordings of past webinars, and access to more and more teacher training courses that are coming up in the future. All right, so I am going to swiftly hand over to Alan. So Alan we're delighted that Alan's joining us today, and he's going to be talking about developing a medical ethics reasoning skills course. So over to you, Alan.
Okay, thank you very much. Can you hear me okay? You can see my slides? Great. Okay, so I'd like to thank Ealthy and SLC for inviting me here today. I really enjoyed the Ealthy conference last year in Serbia. I talked a little bit about this subject, and I want to talk about it a little bit more about how I've been developing a medical ethics reasoning skills course. This is a picture of where I like to go running, just near to where I live, where I work, which is in Miyazaki. Miyazaki is in the south of Japan, and I've been in this region for, wow, going on 20 years now. Miyazaki is a very beautiful place to live. It's semi-tropical, it's next to the Pacific, there's beautiful nature. This is the Sheraton Hotel. We go there maybe on special occasions. And this is a Shinto shrine. Buddhism and Shintoism are the main religions. Shintoism is like a pagan religion. There's various different gods. These are some popular foods. In the top left is, it's like a cold miso soup called hiyajiru. And it's very good in the summer because it can get hot. It can get up to 40 degrees. And in the top right is mango and shaved ice. It's very sweet. Mango can be really expensive. It's good quality, but it can be £50 for one mango. And down in the bottom left is like barbecued smoked chicken called jidori with some sweet potato alcohol, a 20% alcohol called shochu. It's very popular. And down in the bottom right is some Miyazaki beef with like a spicy citrus paste, which is delicious. This is the university hospital next to where I work. There's about 600 beds. And I've been working in the Department of Medical Education for about 2 years now. And there's 110 students per year, 110 medical students per year. And there's about 60 nurses in the Department of Nursing per year. And we have about 4 English teachers in our department. This is an example of an anatomy class in the Faculty of Medicine. And this is an example of our elective EMP course for 5th-year students, quite small group sizes. They'll be doing some role plays, simulated patient role plays, doctor-patient interaction in small groups here. This is our Faculty of Medicine logo. In the middle, you'll see the rod of Asclepius. Now, I've only been working in medical education for a couple of years, but I've been seeing this symbol in lots of different places. So I researched a little bit about it. You might know better than me. Asclepius was the god of, let me see, healing and medicinal arts. And the walking stick, my understanding is that it's to help in the healing process. And the serpent skin symbolizes rejuvenation, life and death, sickness and health. Can the snake drive away disease? Does the venom cure or kill? And in front of the university is a statue of Hippocrates. Now, Hippocrates, he worked at an Asclepius healing temple on the island of Kos. And he's known as the father of medicine because of his rigorous clinical methods. And I asked my students to translate this inscription and try and interpret it. Life is short, the art long, opportunity fleeting, experiment dangerous, and judgment difficult. Now I'm going to ask you 3 questions during this session. The first question is, what is Bruegel trying to show? Now, Bruegel was a 16th century Flemish painter, and this painting is titled The Fall of Icarus. Now, you might well know this story, The Fall of Icarus. Icarus and his father was a genius inventor. They were imprisoned on the Isle of Crete. And his father used candle wax, and he collected birds' feathers, and he made 2 sets of wings for him and his son. And before they took off, he said to his son, "Now, don't fly too high to the sun or the sun will melt the wax. And don't fly too low to the sea because the moisture will make the wings heavy." And they took off, and Icarus was excited, and he soared up into the sky, and he was too ambitious, and the sun melted the wax, and he plummeted into the sea. Just here down in the bottom corner, can you see there? But no one really seems to notice that the farmers ploughing his field, the shepherds gazing up, tending to his flock, and the fishermen's preoccupied fishing, and this ship's sailing towards the town, trading. But no one really notices Icarus here in the bottom right corner. So my question for you is, what is Bruegel trying to show? And I'll give you a minute. Please type in the chat box, what do you think he's trying to show? I've seen a few ideas on the internet. What do you think? Life goes on, indeed. Yeah, I think that life goes on. Maybe some people do notice the suffering for a short time, but they don't really care. They go back to their way of life. And what I want to teach with medical ethics is about how to care. The Japanese Ministry of Education, Culture, Sports, Science and Technology wrote the basic qualities of a physician. They're to understand patient-centered views, great. Culture, okay. Medical ethics, and have problem-solving abilities stemming from the liberal arts. I was really happy to see that. to objectively and critically consider information in science and society. So looking at the liberal arts, not just the science, technology, engineering, mathematics subjects, to develop this critical thinking skills. And about 2 years ago, I had to make a first-year university class, English for medical purposes. My colleague was teaching like spoken discourse, doctor-patient interaction. Another colleague was teaching anatomy terminology, and I had to develop a course. And I talked to my friend, a philosophy professor. He suggested medical ethics, and you could develop reasoning skills in English. And I found that the students are studying clinical ethics in their second year, and I thought this could complement it. So I didn't know much about it, and I got a couple of books, and I read these books. Ethics in Healthcare has got really good case studies in it, and Medical Ethics has got a really good introduction. So I developed a course, Reasoning Frameworks, End of Life, Therapeutic Relationship, Assisted Birth, Human Research, and we study in English. We present a case situation, a case dilemma at the start, and we try and consider various factors about it, different perspectives, discuss it, give opinions, try to justify the opinions, summarize, reflect, and then I give them a case conclusion. What have we not noticed? What can we learn? Where are the gaps in the knowledge? And I'm going to show you some of their presentations they did about 10 hours ago. It's just the end of the second time I'm teaching this course. So I want to show you how I've developed it. So the reasoning frameworks start with logic. Now, the important thing here is trying to make reasons that support the conclusion. So having reasons, you could have reasons, but they don't really support the conclusion very well. So trying to make stronger reasons to support the conclusion. Moral rules, character or virtue, building their values. Do not deceive, keep your promise, follow the law, of course, do your duty. Conceptual analysis, defining things, trying to explain with examples, making distinctions, showing similarities. For example, if a young man has an appendicitis, it's pretty clear he needs it removed. Okay. But if the man has Alzheimer's and has cancer, then it's not as clear the best treatment, what's in his best interests, and who should make the judgment. This is a really good checklist. First, identifying the moral problem, gathering relevant information, identifying the available options, considering but also building an argument, looking at the different perspectives, choosing a course of action, then evaluating the results. Principles. So for example, patient autonomy. Can the patient decide, think for themselves? What is best for the patient? Objectively, assessed by health professionals. Avoiding harm to others. Justice includes having equal access to healthcare resources. Individual rights, at the same time as considering what's best for society. For example, if there's a really expensive treatment for one person, does that affect the treatment for many people in society? Okay, so question number 2 for you. Should a 60-year-old post-menopausal woman be helped to have a child using assisted reproductive techniques? Now, I don't mind with my students whether they think they should or they shouldn't. I want them to think about their reasons. Okay, so I want to give you another minute. Tell me, what do you think? And we're going to look at some of the student examples in a minute or two. Okay, so what do you think? Should they be supported or not, and why? It's a difficult question, right? Let me show you what my students taught last year. This was at the end of the course, and they did group presentations. So this group said their conclusion was that they don't recommend. Yeah, I think it's difficult. That's a good point, Richard, without knowing more about the patient. So this group said they don't recommend it because there's a great risk to both mothers and potential child's health, less time to live together, and there's an economic problem to bring up the potential child. And I said to them, my feedback was, it was good, they did a good job, they made a good presentation. But afterwards, I felt a bit frustrated because I thought they probably could have made better reasons to support that conclusion. Rather than the economic problem, they could have thought about some health-related reasons. So I went away last summer and I did some reading, and I found this paper. I can give you all the references at the end if you're interested. This paper is about medical ethical reasoning model. And what I really like about it is the justification categories. So the probabilities, what are the risks? What's the best evidence? Go and search online, find out some examples. What are the risks? What's the evidence? What are the rules or guidelines? What are the laws? Are there laws? What are the ethical principles? Like what the mother's opinion is. What are the consequences if they do have this therapy? So trying to justify their reasons more makes a much stronger argument. I wanted to focus on that this year. I also introduced counter arguments, helping them to build an argument. So making a decision about what they would do, trying to give a reason, then trying to think about counter arguments against your decision. So it should not be done because A, B, and C. And then step 3, to make reasons to disagree with the counter argument, to support your opinion. Yes, A is important, but X, Y, and Z are more important because of such and such. Trying to use this framework to help them to build an argument. Think about different perspectives to make a stronger conclusion. Now, before I show you the students' examples, I would like to think, or I was thinking, but where am I trying to go? Really, where's the more holistic aim with this? And of course, I'm trying to develop their reasoning skills, but I want to try and help their professional identity formation as well, more longer term. Build the students' reflective capacity, their ability to reflect deeper, write more, give more reasons, and reach towards cross-curricular education in other courses. This model in 1990, George Miller made this model assessing clinical skills, and it had 4 levels in it. It started with knowledge, knows, and then knows how, the competence, and then shows how, performance, and does being the highest level, the action, demonstrating the behavior of a doctor. And then in about 2015, 2016, Cruz and others added an extra level about is, identity. Who is the doctor? Okay, what are the moral values about being a doctor? So rather than just practicing medicine, I am a doctor. Okay, the identity of being a doctor he put on at the top level. What does it mean to think, act, and feel like a physician? And this was written by Robert Keegan. He made an adult meaning-making lenses framework back in about 1982. He was a cognitive developmental psychologist. And he was talking about moving from one lens to the next, or one level to the next, by the individual at their own pace, trying to move from subjective view of themselves to more objective view, focusing on rules and rewards, then more the social norms, trying to build internal values, and then seeing gaps in your beliefs, looking at other perspectives, transforming your ideas. I'd like to look at this socialization level a little bit more detail. So with socialization, the students are bringing their personal, existing personal identities, and they're going through clinical experiences, patient encounters, non-clinical, maybe studying abroad. They have role models and mentors that are guiding their reflection as they develop their personal professional identities. Symbols and rituals are things like the first time they see a cadaver in the anatomy class, they're observing a dissection, they're paying respect to the person that's donated their body. It has a big impact on them. Or when they first receive their white coat as a trainee doctor, or their stethoscope, it is a symbolic kind of ritual in their development of their identity. I'd like to talk a little bit more about this guided reflection. How to build their reflective capacity. The ability, desire, and tendency of students to engage in reflective thought. How can we get them to write more, to reflect more? Understanding the situation, thinking deeply, making a decision with supported reasons, learn about how successful it was with peer feedback, teacher feedback, and trying again, considering alternatives, trying to develop evidence of their learning, their development. Okay, so I want to get into the students' examples, some cases I want to share with you now. So this first case is about Ms. Hashimoto, 45-year-old woman, has ALS, progressive nervous system disease. Oops, too fast. Just a moment, move my screen around. And she was admitted to the university hospital 3 days ago for treatment. And Dr. Suzuki treated her with drug treatment, physical therapy, tells her she's now ready to be discharged, to go home. But she says she feels weak, she's not confident of looking after herself, and she'd like to stay in the hospital. How should Dr. Suzuki resolve this situation? So student W, she said, at first it was difficult to think what to do with Ms. Hashimoto's case. But after learning about reasoning frameworks, it was much easier to think about a solution. So my idea is to introduce a home doctor as long as she feels uneasy. And I thought, That's a good resolution, a good solution. And my feedback to her was, that's good, but I'd like to know how you got to that conclusion. So learning about reasoning framework. So what were the reasons? Why do you think that she should be looked after by a home doctor? I want to know your reasons. Please tell me more reasons. I know she has the reasons. I want her to explain them. Here's another situation. This time we're looking at the value of life, this theme. And the question was about spending money on preventative long-term treatment or short-term rescue treatment. And it's the same student W. And she said that I'd spend money on expensive short-term rescue treatment rather than long-term preventative treatment. One reason is that short-term rescue treatment has an absolute and direct effect. Another reason is that there's no time for the short-term rescue treatment. It'd be the only way to save his life. On the other hand, the long-term preventative treatment has more time. So you may be able to find a more effective way, a more effective treatment or method. So therefore, I'd spend money on expensive short-term rescue treatment. Okay, so of course you could develop it further, but I was happy that she's starting to look at both perspectives. Okay, she's looking at both sides. So I was happy that's a good development. Now let's look at another student, student A, his opinion about telling the truth. So he said that I think it's obligatory to tell the patient the actual, he said symptoms, but I think he means diagnosis. But I think it depends on the occasion. And I underlined that I think that's important. Because I don't think the patient should be confused or shocked out of his or her wits by knowing the truth. And my reflection was, I didn't tell him this, but my reflection afterwards was, it's a good answer, but to make it stronger, we could discuss the specific case. So we could think about specific case. And it could be an opportunity to teach about how to break bad news as well. I've not taught it, but I did study about it, and I could teach that in future. The case was about an oncologist who gave a very direct and insensitive diagnosis to a patient. And I'll just let you read what he said. When I read this from the textbook, I thought, oh my God, I think the students did as well. He told the truth, but I don't think he communicated very professionally. What's a plab fail, Richard? Yeah, I think that, of course, the doctor could have, he used too difficult vocabulary. He didn't explain any options. There's a lot of things he could have done better. And the students could have used examples from this case to give examples. So it depends on the occasion. So in this case, then, what could the doctor have done different? Okay, so student A again, and this time their opinion about adoption and assisted birth. So he said that I think it's okay to have regarding adoption, but I cannot think positively about assisted reproduction. The reason is that I think it's unethical. And I've got to remember sometimes that the students are about 19, 20 years old. So they probably don't have much experience. They might not know about assisted reproductive technology. I wanted to unpack, what does he mean by it's unethical? So I said to him, my reply was, do you think that assisted reproduction is unethical because maybe some of the embryos are destroyed, the ones that are not used? That would be a good reason. Or do you think it's an unnatural way to have a baby? Then what is unnatural? What is natural? How about couples who struggle to have a baby using a normal method? Do you think there should be an age limit because it's safer for the mother and child's health? Give me more reasons. I don't mind what his opinion is. I just want him to try and justify it and try and think of some reasons. So I wanted to ask the whole class about this. I wanted to try and get them to think more about reasons, to try and build arguments. So I went back to them with this question: should a 60-year-old woman be supported to have a baby using assisted reproductive techniques like IVF? And group 3 said, yes, we think that she should. And however, there are health risks of both mother and child. For example, hypertensive syndrome, a risk of disability for children, for the child. Great, they went and got some concrete examples. But we think that if we get agreement of mother for these risks and support of the healthcare workers and family, we must respect her choice. And using frozen embryo can reduce the risk of having disability. So in conclusion, we understand the risks. All pregnancies have some risks. So as long as we explain about these risks, get agreement, we should help her. It's a much stronger argument. Great. Now this is group 5. And group 5, on the other hand, said, no, we don't think we should support this woman. We understand the mother's free choice, and she may have no problem financially and physically, but we think there's a great risk to the mother of gestational hypertension, gestational diabetes, cesarean, anxiety about childcare, risk of a child with disabilities. So in conclusion, even if the mother has no problem physically now, but she has many risks. So we think she should not be helped to have a child. They probably could have made this stronger if they'd acknowledged the mother's opinion, but they think the risks are too great. Would have made it even stronger. Okay. So what I want to go on to now is the group presentations, and the students did it this morning, Japanese time. So that's about 10 hours ago. And then I tried to grab bits of their presentation to show you just now. So my task that I set up was to give them different themes and to do group presentations. Tell me about the background, about the theme, have a case, describe the case, try to reason, justify, build an argument to support their conclusions, and have some reflections at the end. I'll show you 3 groups, parts of their presentation. So this was group 4. They were presenting about end of life. The case description was about Mr. Hashimoto. And I presented this case in class. It came out of a textbook. And so they paraphrased the case. So Mr. Hashimoto's case, he has had AIDS, HIV for 2 years, and he's had several medical problems like infectious diseases, and his present symptoms are shortness of breath, chest pain, cough, and fever. He might have pneumonia, and if he's treated, he has a 70–80% chance of being treated and recovering. If not, he could die within a few days. He does not want to live as an HIV patient. It's been very difficult for him. And so he does not want treatment for pneumonia. So the student said there's 2 choices. To relieve his physical and mental pain. I think they mean here to give him treatment for his pneumonia. And then he would move on to palliative care for HIV/AIDS. Or to fulfill his hope with euthanasia. Now, when I read this, I thought, what do you mean by euthanasia? You mean, and we taught this a little bit in class. We had a unit on it. And I was thinking, do you mean active euthanasia? So the doctor is giving medicine that will shorten his life, that will actually kill him? And I thought, but the treatment for pneumonia wouldn't kill him. It would be not having treatment that would kill him. So I wasn't sure about their definition here of euthanasia. So my thoughts just today, feedback I'd like to give them, is about this conceptual definition of euthanasia. So he could refuse the treatment for pneumonia, but then this would be passive euthanasia. It would be allowing him to die, so the pneumonia would kill him. It wouldn't be the doctor actively doing something. It wouldn't be active euthanasia. And the students went on to explain about that passive euthanasia is okay sometimes in Japan, but active euthanasia is not. But I wasn't sure that they were clear about what the difference was in this case. So I think that if he chose not to have the treatment, then it would be, he would live a shorter time, but it would move to palliative care for a few days, these few days. So I wasn't sure about their definition at the start of the presentation. The conceptual definition. It was difficult for me to think about as well, to analyze. Let's look at another group. And they presented about modern genetics. And I'll take you through their case and their arguments. Okay, so this is a case about two sisters. And Helen's son has been diagnosed with a severe, debilitating and progressive muscle wasting disease. Children with this disease have to live in wheelchairs during their teenage years and usually die in their 20s. The disease is hereditary only for boys. So the mother can carry it or the female can carry it, but it's only the disease only occurs in males. Helen has a 10-week pregnant sister, Penelope, who may also be a carrier of this gene. And Helen believes that Penelope may have an abortion if she learns of this possibility. So Helen doesn't want to tell the information to her sister. She doesn't believe that that's the right thing to do. So in this case, there's two ways to think about it. So the students went on to explain. And again, we had studied this in class and they're paraphrasing it and representing it for this final presentation. So the personal account model is a traditional view. And this view is Helen's idea. So the genetic information belongs to Helen. There's no need to tell it to Penelope, her sister, even if it could be harmful to Penelope and Penelope's child. On the other hand, the joint account model, the genetic information is different from other personal information. And it could affect other people in the same family. So it should be told to Penelope because it affects her as well. So two different models. So this group chose the personal account model very clearly. They chose, okay, we choose this one. The fact that Helen's a carrier is not only a problem for her, but also affects her sister. So they are taking into account the other point of view. And it makes sense to tell Penelope about that. But Helen doesn't want that. And in this case, we believe that if we're to tell Penelope that Helen's a carrier, it would be an invasion of Helen's privacy. So they think that the patient autonomy, Helen's privacy is more important. Their conclusions Who has access to this genetic information? Who does this information belong to? And they're looking at both sides. The personal account model protects Helen's wishes, information, but it doesn't consider Penelope's fetus health. And the joint account model, Penelope can know the risks, but it would break Helen's confidentiality. So they chose the personal account model, but they acknowledge there could be harm to Penelope's child's health. And they would like to go with the patient's request. The individual privacy is essential, even within families. So I'm not sure if I agree with them, but I think that they have argued the case, they presented the case, they looked at both sides of the case, they said which one they thought was more important, and they made a strong argument. So it depends on the case, is my reflection. And I asked them at the end of their presentation, so how would you support Penelope? And they thought about it and they said, well, I think we would tell Penelope to have genetic testing, maybe of this or that, so that she can find out without breaking the confidentiality of Helen. So it was a creative solution to get around this difficult dilemma. Okay. The next group one, they did a presentation about the start of life. And their case is about the Suleiman octuplets. Amazing story. Nadia Suleiman already had 6 children, and then she gave birth to 8 new children through IVF. Wow. However, she had some troubles. And then the students presented the advantage was that this kind of technology could help people that have trouble getting pregnant. So Nadia suffered from endometriosis, difficulty becoming pregnant, and now she could become pregnant. And this treatment depended on her will, her choice. However, there was risk of premature birth, risk to the baby's health, risk of complications, and they listed some examples. Great. They didn't state their opinion, but it's quite clear. And they got this information from the American Society for Reproductive Medicine, who recommend no more than 2 embryos for women under 35, no more than 5 for women over 40. But this doctor transferred 12. Oops. And he was expelled from the society for this treatment and another patient as well. What I really liked about the presentation was this reason, was the effect on Nadia herself after the birth of all these children. So it had a big negative effect on the family. It was great that she could give birth to so many lives, but the students were able to evaluate the consequences of this treatment. And because they could see it in this case, it had finished, so they could look at the results of this treatment plan. Okay, so what I'd like to do is next week is my last class with these students, and I want them to do some more reflective writing. I'm going to get them to write about this course, and especially I want them to think about some examples of critical incidents in their presentations or throughout the course. with supported opinions and strategies, thinking critically, objectively, trying to look at the different perspectives they demonstrated a little bit in their presentations and the consequences of that group. And I want other students to think about consequences as well. And I'd like to share the students' course reflections. I'll probably write a follow-up blog post for Ealthy, so you can see what the students thought. Now, I talked to one of the clinical ethics professors just this week, actually, about the course that he's teaching. And I wanted to see if this would bridge to their other courses. In the second year, they do a clinical ethics course. And I was really happy to see that they're teaching or they're studying bottom-up ethical approaches, treating the person rather than disease, great. Narrative-based medicine is the patient's story, how to communicate with the patient effectively, listen to them. Professionalism, I'll come back to at the end. And then in fifth year, it's much smaller groups, or 6 students, and they're looking at daily ethical issues in the hospital, focusing on the patients and families, cooperating with different kind of professions, medical professions, making a team, everyone's helping each other. This one was interesting about mindset and kindness are not enough because it really depends on the specific case of the patient. I thought that was interesting. And I'd like to learn more about the ethics case conference discussion method, how they get together in a group and they brainstorm and they discuss each ethical case. Now, you may know this Declaration of Geneva, the Physician's Pledge, where they aim towards becoming doctors. And what I noticed with this was, I will respect, I will maintain, I will practice, I will give, I will share, I will do all these things. But what I thought was missing is, what's the difference between doing and being? What's the difference for me with teaching or being a teacher, my identity as a teacher? It's a kind of philosophical question for you. What do you think is the difference between doing and being? And I'll give you maybe a minute to think about that just before we wrap up. If you have any ideas, please feel free to write them in the chat box. I think for me, I can't speak for doctors, but as a teacher, I think it's been quite a big difference in my development. Thinking about teaching, what I teach, what I do, with my identity as becoming a teacher and thinking about students. So I think that there is a difference. And I think that it's the same for doctors, becoming a doctor. Being is live your values. Indeed, Richard. And developing those values as well. Yeah, I think I'll leave you with that question. It's a good one to think about, right? And so this is really my last slide. I'd like to talk about professionalism. So there's accepted norms for medical doctors. Most people agree. I read an interesting paper which said that doctors should also be able to resist standardized solutions to contemporary problems like modern genetics or systematic problems in the hospitals, for example. So I think that we as educators should identify the skills, knowledge, and attitudes necessary for student doctors to be able to question, challenge, and disrupt. Disrupt is develop, evolve the system, which actually help them to form their identity so that they may fulfill their mission to their patients. And this is really the top of critical thinking, transforming their values, being true to their own values, but still focusing on each patient, each situation. These are my references if you'd like to look anything up. And thank you very much.
Thank you, Alan. That was
Thank you.
Fascinating, very thought-provoking, and I found myself talking on mute, talking and trying to answer your questions as we were going along. So we've got a few moments, everybody, for questions. So if you've got some questions for Alan, if you could pop them into the question and answer section, and then we'll be able to hand them over to Alan, who will be able to answer. I think I'll kick off if that's all right.
Sure, I'll stop sharing.
I was wondering, what did your students find the most difficult part about your course?
Good question. I'll ask them next week. I think that I was having a look at the presentations yesterday, and they hadn't really developed them. So I think probably time. I think that some of the groups I didn't show you, like developing that reasoning, justifying. So having a case, having a fixed case, it's easier to think of things in more general terms. But when you look at a case, then you try and look at both perspectives. So getting used to that kind of thinking of different perspectives, building an argument, getting them into that mindset. I think that they were quite good at sharing their reflections at the start of class with each other. I wanted to try and get them to do that in English, but really just getting them to try and explain more, reason more. I don't think it's that difficult to do, but getting them into the habit of doing that. Yeah.
Okay. All right. So
of course, sorry. Of course, the content is also new and difficult for them. Like, for example, assisted reproductive technology, a lot of them, it may be the first time they're exposed to that theme. So, and it's in English. So it's doubly challenging, I think.
All right, so we've got a couple of questions. Got a follow-on question here from Leftina, sorry about my pronunciation, which I think is related. So the question is, what's the most challenging part of doing the course? I wonder if that question is related to what's the most challenging part for you of doing the course?
I think it's been challenging for me because I knew nothing about medical ethics, to be honest. And but I think that that's also been very rewarding for me. I've put in a lot of effort in studying about it, developing it, presenting it. I presented it last summer, presenting it just now. So, for example, that pushes me and challenges me to justify why I'm doing this. Why am I trying to develop the reasoning skills to think about their more longer term identity formation and what does that actually mean? And so I've been forcing myself to research about it as well. So I think that that's been satisfying at the same time it's been challenging. So some classes I might just use a textbook and I don't put as much into it, but I get much more out of this, even though it's more challenging for me.
Right. All right. And we've got a question in the chat here as well. The question is from Richard. It says, you've talked about students discussing their ethical issues with each other, but do you also run sessions with them when they discuss these issues with patients?
No, it's a quick answer. It's a good question. I was talking to the clinical ethics professor. I've not met him. I was talking to him by email just recently, and he was very interested in what I'm doing. And he said, "Do you have a clinical ethics qualification?" I thought, "Oh, he's going to get me into trouble." But I think he was more being supportive because he was talking about clinical ethics society in Japan, and I said, "Do you have anything you would recommend? I'm interested in maybe doing some training and getting qualified." And I think that for him, when he's teaching the students in the 5th year, they're doing their clinical rotation. So they're in the different departments and they are they're able to, part of his course, he would take them into the hospital. They would be able to listen to patients, probably not ask them questions, but they could probably observe the other doctors, the clinical ethics or whoever other doctors talking to the patients, and they will be looking at real patients' cases. But I think that at my stage or my student stage, they're only first years, so they are, although I would like to get, if I can, from this clinical ethics professor, to get some example cases, if it's okay for him to share them with me, I would like to use some cases that he's willing to share. That would be great. Yeah, of course.
Interesting. All right. Okay. And we have a follow-up question. So I think this will probably be our final question. So how much, the question is, and there's an explanation as well, the question is, how much grounding do you give them in legislation? And then the follow-up is, so much medical ethics is based in law. For example, your Helen Penelope scenario. I think in the UK, the doctor would be obliged to disclose the diagnosis to avoid exposing the sister and baby to harm. That's an interesting question. I was wondering the same kind of thing as you were talking, actually. So going back to the question, it was, how much grounding do you give them in legislation?
How much am I able to give them is the question. Not much, but I think that what I did with this case, actually, the students had different opinions. Most of them were on the personal account model because it's more a traditional. And then I looked at some research from the States, actually, which was a familial model, which is the family kind of model. The information should be shared, which I think is the same as the UK. But the research was saying that it does depend on the case as well, and how much harm it could do to the family. So I think that may come into it. The doctor would probably try and understand each case before revealing the genetic information. The other example was about euthanasia, and what I did was I asked the students to go and find out about Japanese law. Let's research it together, find out in Japanese, and then let's teach each other. And they struggled to find out about the law, and because some of it's not that clear, and we were looking at a university law guidelines and things like that, and we could find some evidence in some definitions of active euthanasia, passive euthanasia, and the different categories. So that was very important, I think, for them to go away and research it themselves rather than me providing it. And I'm not even that confident in providing, especially not in Japanese. They're better at going and finding that out themselves and then sharing it with each other. I think that's a better way to do it. I think it's more authentic that we go and research it if we don't know.
Great. All right. Hello, we're going to wrap up. Thank you so much, Alan.
Thank you.
That was really interesting. I think I need to go away and perhaps have another cup of coffee now to recover from all the thoughts. Thank you to everyone for attending. And thank you again, Alan, for giving your presentation. Really fascinating. And we will be back with another Ealthy webinar in the next month or so. So watch out on our page for when that will be and what that will be. And we look forward to seeing you again. Thanks very much. Bye.